Good morning, everyone. We're just gonna start in a few minutes. We're gonna give folks a couple of more minutes to get signed in here. So just bear with us about 2 or 3 more minutes. Thank you. Okay, we're gonna get started. Good morning, everyone. Thank you for joining the Georgia Clinical Quality Measure System webinar. My name is Christy Washington, and I'm the Pop Health Research Data Analyst here at the Department of Community Health, and I'll be your moderator for this webinar. This is part 4 in the Take 5, How eCQMs Improve Patient Care and Outcomes webinar series. Winter Laws with DXC Technology will present an overview of the program, followed by a system presentation by Teresa Harris with DXC. We will deep dive into 3 CQMs for pediatric care with Chris Huckabee with Health Tech Solutions, and a clinical perspective will be given by Dr. Carol Steffenkamp. This presentation will show the system capabilities and functionalities, including how to enter clinical measure data and generating provider performance comparison reports. I would like to remind everyone of a few housekeeping tips. Please hold all your questions until the Q&A session. At that time, please raise your hand and you will be unmuted to ask your question, or you may type your question in the question pane or the chat pane, and we will read your questions aloud. This webinar is also being recorded. The presentation as well as the recording will be available on the DCH website. This presentation is also available for you to download in the handout section. If you're having difficulties getting that presentation there, you can send us an email at hit.info@dch.georgia.gov. Again, that's hit.info@dch.ga.gov, and we'll be happy to send you a copy. At the end of this webinar, there'll be a brief survey, and please just take a moment to complete that survey for us. At this time, I would turn the presentation over to Winter. Thank you.
Hello, everyone. Thank you for joining the call. We are excited to have you participate in this webinar to discuss the Georgia Clinical Quality Measures Project. As she stated, I am a senior project manager for DXC Technology. I've been working on this project for a couple of years with all of the other presenters, Christy Washington, Teresa Harris, Chris Huckabee, and Carol Steltenkamp. Next slide, please. The mission of our project, the mission of the Department of Community Health is to provide access to affordable, quality health care to Georgians through effective planning, purchasing, and oversight. And as a result of the Georgia mission, they have asked us to work with them to provide this new and different application. Purpose, please. Next slide. We're working with them to shape the future of a healthy Georgia by improving access and ensuring quality to strengthen the communities we serve. So that is a huge opportunity for us, and we are looking forward to working with Georgia and you, the provider community, to help make this application be impactful for the Georgians that we address here for the state of Georgia. Next slide, please. What will be included in the agenda today is an introduction, a project overview, the benefits of the project, and the eCQMs overview. The system itself will be reviewed. And we have also where we're actually going to talk about 3 specific CQMs, 146, 154, and 155 will be given an overview. And we have a Dr. Steltenkamp who will be joining us and providing a clinical perspective, which we hope will identify with you, and we hope that you will take the opportunity to ask her questions or any of us questions during this process. There will be a specific question and answer at the very end, but also let me encourage you in terms of if you want to communicate with us some specific questions even ahead of time, please feel free to use there's a chat section in the presentation that you can send in your questions there. And we also have a scenario where we're going to do some polling questions as I go through the slides. And we encourage you to respond to the polling questions. Although the people that are presenters or DCH or DXC Technology participants don't have to respond, we're looking specifically from you, the providers. We want to know what you think and how you feel and what's going on in your environment and area. So again, please use the chat, respond to the polling questions, and let's have a good time as we're going through this. I want to go through the project overview now. This particular project is a scenario where we're implementing and operationalizing an effective way to accept clinical quality measures, the information from providers across multiple channels to support the program goals. We are also assessing trends against various benchmarks, i.e. the member disease categories, specific provider geographies, or a subset of provider types. We do this through a phased approach to gain insight and lessons learned for an effective rollout to a larger community. And I want to spend just a second talking about that when we say something about a phased approach. The phased approach is a scenario where we ask for providers like you to sign up with us to input the data specifically around the clinical quality measures on a quality basis. We get that information, we look at it, and work with you. You also have an opportunity to look at the data that's in the system. We give you an ID and things like that, and all of that will be talked about a little bit later. But as a part of a phased approach, it'll be a scenario of us working with you to get you signed up. Once you give us the data and work with us, then there are people at DCH and others that'll be assessing the data, and then we'll come back together as a phased approach and talk about the data and assess it, analyze it, and determine next steps that'll enhance the project. Next slide, please. This is one of those polling questions that we are encouraging you, the provider, to respond to right now. And the question is your practice currently looking for an effective way to capture clinical quality measures? At this time, please answer yes or no to this particular question. Can we take a checkpoint to see if those have responded? Hey, Christy, you want to do a check? Thank you. Excellent. So everyone wants this type of thing. So this is great news for us. So next slide, please. So let's talk about the project benefits, because that is exactly why we are here presenting to you. This particular project, we believe, will improve health outcomes for the Medicaid members, aligning with CMS's direction through the effective use and comparison of provider-generated data. We have created a platform from which the department can perform consistent, rules-driven evaluation of effectiveness for value-based purchasing outcomes, improving health outcomes, and informing providers on performance compared to peer and state norms. Excuse me, I was having a little trouble with that one. But ultimately, the three goals of the healthcare system is to better care, smarter spending, healthier people by way of care delivery and information sharing. And this kind of goes back and forth. So as we work together through the system, we can make these types of things happen. Next slide, please. We've got another polling question. Yay. So it says, would comparing provider data to state average data benefit your practice? Would comparing provider data to state average data benefit your practice? Excellent. That's good news. So let us go over the CQMS system at a high level. And with that, we're going to turn to the next slide, and you can see that this particular system and what we're doing as a project will be to train to leverage certified EHR system capabilities. And we want to work with your EHR, or sometimes it's called EMR, to pull in the information, the CQMs, and that would allow you to use the system electronically, if you will, to bring the data into the GACQMS. We also accept the QRDA Cat 3, or there is a manual entry scenario for the CQMs if there's seems to be some issue of sending the file electronically to the system. We also have the ability to do manual entry. Once that information is in, we display the provider measurement data via a GA-CQMS dashboard. And you're going to get a chance to look at this capability and these type of reports here in just in a few moments when it's time to walk through the system itself, when Teresa does that. So it says something about manual entry of the CQMs, and you saw that on the second bullet item. If you would like, we have the capability of providing a data entry clerk to you such that we can enter the data for you if you like. It is one of the benefits of working with our organization to bring that data in, and we've done it for a couple of our other providers that are participating in this project. So in this initiative, if you would like to do that, we can also make that happen for you. Next slide, please. Additionally, we have a clinical advisory board that meets quarterly to discuss the outcomes of the program and the initiative. What ends up happening is that they discuss clinical assistance. They look at the CQM measure selections that are in the system. There's recommendations on how to use the data and the reports, as well as collaborative support with DCH and provider participants in shaping the program, the initiative. So we're working together, about 10 or 15 clinical people, leadership from DCH, DXC, and HTS. As we're bringing in this data, we're looking at your information and assessing it, and also getting feedback from you as a clinical advisory board. Next slide, please. This is a scenario where we've got another polling question. Would you utilize trend analysis or reporting to monitor population health? Would you utilize trend analysis or reporting to monitor population health? Excellent. What I'd like to do now is share with you the current project status and where we are with our project. We went live last year in April, and we have 7 participating provider organizations. We have 84 individual providers loaded into the system, 7 CQMs, of which 1 will be loaded. And CQM data is loaded quarterly for analysis. In fact, we just opened up the second quarter where we can add second quarter data on July 15th. And 1 organization has already provided their information, and it's already loaded into the system via the data entry manual, via our data entry clerks. And we're working with the other organizations and providers to get their data loaded into the system. Let me go over specifically what clinical CQMs we have in the system right now. What we have in the system right now that we're collecting data on, next slide, is CMS-2, preventive care and screening for depression, CMS-69, preventive care and screening from a BMI perspective, CMS-122, diabetes, CMS-125, breast cancer screening, and we are removing, because CMS retired it, CMS-126, CMS-165, controlling high blood pressure, and CMS-153, chlamydia screening for women, are all data that we're currently bringing into the system. We do have a project right now, an initiative where we're expanding the measures. For the next slide. And we're adding 7 measures: CMS 90, functional status assessments for congestive heart failure, CMS 128, antidepressant medication treatment. CMS 136, follow-up care for children prescribed ADHD medication. CMS 146, appropriate testing for children with pharyngitis. CMS 154, upper respiratory infection. CMS 155, weight assessment, counseling for nutrition and physical for the children and adolescents. CMS 177, child and adolescents major depressive disorder and suicide risk. Those are the ones that we're adding. We're in the process of working through and testing, and that will be added to our system and accessible in September. So there's a next polling question that we want to ask you. Has your practice spoken to your EHR vendor about QRDA files for clinical quality measures? Has your practice spoken to your EHR vendor about QRDA files for clinical quality measures? Okay, thank you for sharing that information with us. At this time, I'd like to introduce to you Teresa Harris. She is a senior developer for DXC Technology, and she is been on the project since the very beginning, and so she knows the system very well. So she is actually going to walk through some slides that have some of the screenshots for the system. Teresa Harris.
Good morning. Good morning. Welcome to the webinar. I'm excited that you guys are on board today. We have an awesome system that we're going to be sharing a few screens with you to let you know how awesome the Georgia Clinical Quality Measure System is. Once you become an active participant in the system with the program, you'll be provided with a login ID and password. And from that point, you'll be given the information to log in. And then from there, you'll be on your way to see the clinical quality measures we have in the system for you. Thank you. So once you log into the system, each person that logs in will be displayed with a dashboard. It will be your very own dashboard for your organization. So you will be able to see the different clinical quality measures along with the state average. Currently, we are collecting CQM data on a quarterly basis, and as well as the state average is also developed as with the quarterly information. Once you are able to log in and see your CQM data there, the great part about the CQM data, we have what's called a trend graph. So once you click on one of the CQM IDs, you'll be able to see the trending for that year that you're looking for your data. For example, for 2018, for Q1, we're looking at chlamydia screening for women. So we're able to see that the state average is at 41%, but for me, my measure is at 59% for Q1. So I am doing great right now with chlamydia screening. Also for chlamydia screening, we have a stratum information that will also be displayed. So once you click on the CQM ID, the stratum graph will also appear. So question, how do I get my information into the CQM system? How do I get that data so I can see my, my dashboard? The Georgia Clinical Quality Measure System right now has two ways to enter data. We have a manual entry capability, and then we also have a QRDA Cat3 where we can accept the QRDA Cat3 summary file that your EHR vendor will be able to produce for you on a quarterly basis. For the manual entry, as Winter spoke earlier, we have some data entry people that will be able to assist you with that, or you may also do it yourself by clicking the manual entry button. Once you click the manual entry button, you will be presented with the different clinically quality measure items. And there you will be able to enter your numerator, denominator, sometimes exclusion, and sometimes there's an exception. It's all based on the CMS requirement standards for that measure. At the end of entering your CQM data, whether it's manual or using the QRDA 3CAT file, you will be presented with a summary page, and it will, it will display the CQM details. So from the summary page, you'll be able to just do a quick glance at the data that you entered for each measure. For example, CMS ID 2, which is preventive care and screening for depression, on that entry, I did a numerator of 12, denominator of 25, exclusion 2, and an exception of 1. So we like to do the summary page view just as a quick glance to make sure that, oops, I didn't make any just simple mistakes. But from there, you can also look at different ones. You may be able to expand or collapse and then move on to the next one.
Thank you so much, Teresa, for sharing the perspective of how we could enter data and collect the data for a provider. At this time, we've got Chris Huckabee, who is a provider herself, actually in Tennessee, and she will be presenting a deep dive on 3 CQMs, CMS 146, 154, and 155. Thank you, Chris.
Thank you, Winter, and hello to everyone. The first measure that we're going to take a deep dive into is CMS 146, appropriate testing for children with pharyngitis. Next slide. So this measure is looking for the percentage of children 3 to 18 years of age who were diagnosed with pharyngitis, ordered an antibiotic, and received a Group A streptococcus test for the episode. In the denominator is included those 3 to 18 years of age who had an outpatient or an ED visit with a diagnosis of pharyngitis during the measurement period, and they did receive an antibiotic on or 3 days after the visit. Specifically targeting for the numerator is those children that had a Group A strep test in the 7-day period from 3 days prior through 3 days after the diagnosis of pharyngitis. Next slide. So for this measure, we have 2 exclusions. Those children who have been taking antibiotics within the prior 30 days of the diagnosis, and those who were receiving hospice care during the measurement period that overlapped during that measurement period. There are no denominator exceptions for this measure. And the improvement indicator is higher score indicates better quality of care for these pediatric patients. This is an episode of care measure that examines all eligible episodes for the patient during the measurement period. So if the patient comes in multiple times during that 90-day measurement period for complaints of a sore throat, each episode should be included for this measure. The estimated economic cost of pediatric streptococcal pharyngitis in the U.S. ranges from a staggering $224 to $539 million per year. This includes the indirect cost that's related to the parental work losses, but thinking on a broader canvas, the economic cost of antibiotic resistance varies, but the extent has ran as high as $20 billion in excess for direct healthcare costs per year. As we know, treating pediatric patients with pharyngitis, strep bacterial infections, and viral infections often produce the same signs and symptoms. And we know that most often this is viral in nature. The American Academy of Pediatrics, the CDC, and the Infectious Disease Society of America all recommend a diagnostic test to confirm strep A to improve that diagnostic accuracy and to avoid the unnecessary use of antibiotics. Next slide. So how having this aggregate data helped me to improve the care to my pediatric patients? So as a participating provider, when I log into the Georgia eCQMs, this that you see is the landing page. This is the dashboard. Well, I can see pretty quick that I'm at 76% for this measure as compared to the state average of 12. I'm doing pretty good. In other words, I have identified more of my pediatric patients that have come to the office with sore throat symptoms, and I've performed a strep test. But then I had to ask myself, am I happy with that number? I'm well above the state average, but would I like this a little higher percentage? This should prompt me to be thinking of ways either to improve the health care for this patient population or to continue what I've been doing because I'm pretty happy with my percentages. Having this data readily available will help me to improve this care. On the next slide, I can also see how well I've been doing on this measure over the course of a year. So this is a trend line graph that shows the trend over 4 quarters for 2017 for this measure. So I can see how I have trended for this measure over the 4 quarters. And in quarter 1, I was below average and made a remarkable jump in quarter 2 to move up to 85%. Next slide. So the next measure is CMS 154, staying on that antibiotic theme. This is the appropriate treatment for children with upper respiratory infections. So this measure description is percentage of children 3 months to 18 years of age who were diagnosed with an upper respiratory infection and who were not dispensed an antibiotic prescription on or 3 days after the episode. The denominator is looking for those that are 3 months to 18 years of age who had an outpatient visit, were diagnosed with an upper respiratory infection during the measurement period, and specifically targeting for that numerator the children that did not receive a prescription for antibiotic medication on or 3 days after the encounter. Next slide. So for this measure, we have 3 exclusions. We're going to exclude those patients who were taking antibiotics 30 days prior to the date of the encounter when that diagnosis was established. Also going to exclude those who had an encounter with a competing diagnosis within 3 days after the initial diagnosis of the upper respiratory infection. And again, those who were in hospice care and that care overlapped the measurement period. Again, there's no exceptions for this measure, and a higher score indicates better quality. Most of the upper respiratory infections are caused by the common cold, and or by other viruses that require no antibiotic treatment. Inappropriate use of antibiotics can lead to antibiotic resistance, and in the U.S. alone, there were multiple antibiotic resistance diseases and even caused 23,000 deaths each year at a cost of $30 billion to the U.S. economy. Antibiotics should not be used for the treatment of cold symptoms in children or adults. Supportive therapies such as NSAIDs can reduce the pain that is secondary to the upper respiratory infections in adults, and decongestants, antihistamine decongestant combos, and intranasal sprays may improve cold symptoms in adults. Next slide. So again, we go back to our dashboard, and the first thing that I can recognize for CMS 154 is that I'm doing a little bit better than the state average for my pediatric patients who present with upper respiratory infection symptoms. The second thing that this lets me know is that I'm at 70% as opposed to the state average of 52. So again, I would need to evaluate if I'm happy with that number, what else can I do for that 30% that remain. I should be thinking about education, maybe for the patient or the parent. That treatment of viruses does not require antibiotic therapy. And again, on the next slide, I can see my trend over the year for 2017. So I can see by this trend graph, I was well below the state average in Q1, and I can see that the interventions for this particular patient population has improved, and the reduction of unnecessary antibiotic therapy. I began the year at 30% and ended at 74%. Next slide. So our last measure that we're going to do a deep dive into is CMS 155, the weight assessment and counseling for nutrition, physical therapy, or physical activity for children and adolescents. For this measure, now this measure is one of the more difficult measures to trend and track. We have 3 different patient populations that we're looking for. We're looking for the percentage of patients 3 to 17 years of age who had an outpatient visit with their PCP or their OBGYN and had evidence of the following: percentage of patients with height, weight, and BMI percentile documented, the percent of patients with counseling for nutrition, and those with counseling for physical activity. The denominator is going to include those 3 to 17 years of age with at least 1 outpatient visit with their PCP or OBGYN during the measurement period. The numerator is targeted to 3 population groups: those patients who had height, weight, and BMI percentile recorded for the measurement period, those patients who had counseling for nutrition during the measurement period, and those who had counseling for physical activity during the measurement period. Next slide. So who are we going to exclude from this measure? We're going to exclude those who were pregnant during the measurement period, and then again, those who were in hospice care that overlapped the measurement period. There are no exceptions for this measure, but this measure has another additive, which is the stratification. So they're going to report the total score for each of those 3 patient populations, and each 3 patient populations also have strata. The first stratum is patients aged 3 to 11, and stratum 2 is patients aged 12 to 17. Again, the improvement indicator is higher score indicates better quality of care. One of the trends that has been developing over the last 2 decades is the emergence of the new disease, childhood obesity. This rapid increased prevalence has been one of the most challenging dilemmas facing providers who care for this population. Statistics from the National Health and Nutrition Examination Survey from 1999 to 2000 reveals a continued increase in the number of obese children. From that data, the BMI in the 95th percentile was 10% in those 2 to 5 years, 15% in those 6 to 19 years of age. When adding in those children at risk for obesity, the 85th to 94th percentile, the percentage grew to 20 and 30% respectively. This equates to 1 in every 4 children seen by a pediatrician or PCP is either obese or considered at risk to becoming obese. Those who are obese or at risk of becoming obese as children have a higher rate of obesity in adulthood. The visit must be performed by a PCP, pediatrician, or the OBGYN, and the BMI norms for youth vary with age and gender. This measure evaluates whether BMI percentile is assessed rather than the absolute BMI value. Next slide. So again, we can see for our patient populations, the first two are shown on this graph, CMS 155A and 155B. I'm doing a little bit better, again, than the state average. The second thing that this lets me see rather quickly is that I'm at 54% and 66% respectively, as opposed to the state average of 25%. For CMS 155A, which is the height, weight, BMI documented, I'm at 54%. So I have to ask, am I happy with that number? Should I be closer to 100% for the pediatric population? As a provider to pediatric patients, I know that I should be capturing the height and weight for each visit. Maybe additional training for the office staff on the importance of correctly documenting the height, weight, and BMI might improve this measure. And again, on the next slide, I can see how I have measured up for the year. And then you can see on the trend graph that back in Q1 that I had some work to do to help my pediatric patients with their weight assessment and BMI. And I can use this report to see how well my interventions with this patient population have improved or not. I would also like to point out on the next slide that those measures that have stratification, when I click on the number or the CMS ID, a trend graph bar graph will appear for the stratification. And I can see that for the stratum 1, age 3 to 11, what my stats are at 92%. And then I can also see for my stats for the second stratum, age 12 to 17. And as you can see, this system can give you targeted information that can be used to improve office processes, patient education, and target specific patient populations to improve health outcomes. Winner, back to you.
Thank you so much. I appreciate that. We now have a clinical perspective with Dr. Carol Steltenkamp, who's an MD and an MBA. She has quite a length of experience that we believe would be of value and interest to you. So we're asking Dr. Carol to share with you her perspective on this system. Dr. Carol?
Thank you, Winner. And good morning, everyone. Like everyone else, thank you. I want to thank you all for joining our webinar this morning. Chris Huckabee gave a marvelous overview from a pediatric perspective. I am a practicing general pediatrician, so I appreciate those words of wisdom, Chris, that you offered us. And I just really want to start out by suggesting to those folks that are on the webinar today that we go into the office each day and our goal is to provide the best care we can for our patients. And the measures that Chris outlined, including the other 4 that are going to be coming on board, the total of 7, really are helping highlight what has been proven to be the best care, how we can optimize our patient care. So I guess one of my thoughts around doing this are, why not? Why wouldn't we do this at this time? I will say that initially, one of the pushback from providers was, I don't have time. My EHR won't do this automatically. I can't do it electronically. But now, Winter pointed out that there's now an opportunity to have the project assist you with data entry. So we are trying to remove those barriers. I am a member of the Clinical Advisory Board. So as part of that, we do take a look at what our outcomes are here in Georgia. And also I'm also available if there are questions after this presentation. I'm happy to answer those. And you can reach me through Health Tech Solutions as part of the project. So in saying that, I want to get back to the concept that it's our goal to do the right thing. I also teach, so that's always one of my standard lines, do the right thing, even when no one is looking. And it is part of the CMS goals. We, as mentioned earlier in the presentation, better care, lower cost, and healthier communities. So we touched on the better care. How can you do it? Make it part of your standard work. Measuring height and weight and calculation of the body mass index, I imagine, are something that you automatically do as part of your well-child checkups. So those come through. Now then it becomes part of standard work as it relates to using that measure as an example, talking about counseling about nutrition and exercise. Maybe even a better example for standard work for you would be the pharyngitis example. A patient is being groomed by a member of your staff, if you're the practitioner, or maybe we have staff listening. Make it the standard work. You're putting a patient in with the chief complaint of pharyngitis. You may put other notations in, all right, it's pharyngitis without other symptoms of an upper respiratory infection. Well, so then the work becomes that a strep test is automatically performed in light of that chief complaint. Just some thoughts. Again, make it standard work for your group. That's what the strategy goals are looking to do, is we do look to improve care, lower the cost. Chris did a great job in pointing out some of the cost effects of these measures, and when we aren't providing the best care, which we all want to do, and that obviously then leads to healthier communities. By nature, I would say to you, as I touch on this third bullet, we are all, as providers, there's a bit of competitiveness in us. We want to do the right thing, and we want to do it every time. This allows us an opportunity to look at our data. How are we doing? And I'd suggest to you that it's time to do it now while there are no penalties truly associated with doing the right thing. Now, with no penalties, get used to it. Make it part of your standard work so that in the future, when you're able to get bonuses for doing the right thing in comparison, you are way ahead of many of your colleagues throughout the state of Georgia. So I would encourage you, you're doing the right thing. You want to take the best care for your patients, and we are now, that's putting you ahead of others. I will share a little personal experience. My oldest son is a third-year pediatric resident at Memphis at Le Bonheur Children's. That said, he and I were having a conversation around this about a week or two ago around measurement of quality. And I will say I was impressed that it is part of his education now as a resident that they understand this. So I would also suggest to all of you, this is something that the new providers are getting used to, and will come a time that they will expect it because they are being measured in their clinics now as trainees. They will be looking for it into the future. So it's the right thing to do for our patients. It's going to improve the quality of care, and ultimately we'll have the opportunity to improve your reimbursement. So I'm open for any questions, and we'll turn it back to you, Winner.
Thank you, Dr. Carroll. I loved how you shared with them how, from an applications perspective, how they can incorporate that information into their practice. And congratulations to your son for being a third-year resident.
Thank you.
At this time, it is open for question and answers, and we are looking for you to share via the chat, or I believe that Christy will unmute all of the participants. So if you've got a question, please feel free to share it with myself, Dr. Carroll, Chris, or Teresa Harris, anyone that has participated in the presentation. Any questions? Well, at this time, if there are no more questions, what I'd like to do is to offer you an opportunity to send us an email or a telephone call. Maybe you want to take this information to your leadership or someone in your organization that you believe this might be beneficial to them. Our organization email, it is gacqms@dxc.com, and our telephone number, if you would like to speak with us, is 1-866-211-049. Again, that number is 866-211-0949. And if you want a copy of the presentation, if you would like to speak with us, any of those items, we would love the opportunity to have you participate. We need you, providers, to join this particular initiative to make a difference for the state of Georgia. Back to you, Christy. That's it.
Okay, great. Thank you so much, Winner. Thank you so much, everyone on the line. Dr. Carroll, Teresa, Winner, thank you all so much. And thank you, Chris, as well. Our next upcoming webinar will be on August 27th, 2019. And thank you all so much for joining us today. Everyone have a great day. Thank you.
Survey.
Oh, excuse me. And yes, please don't forget the survey following the end of this webinar. Thank you.